go ahead and do a warm welcome to everyone that's able to join us. My name is Mernell Gomez. I am with the Center for Youth Wellness here in San Francisco, and I will be co-facilitating the ACEs provider training along with our amazing trainer, Carissa. Want to introduce yourself?
Hi. Good morning, everyone. My name is Carissa Luckett. I'm welcoming you from Dallas. Hope you're having a good day there. I will be working together with Mernell today to provide some training for you with regard to how to implement screening, your specific protocol, as well as some scripts that we can go over to help you talk about ACEs with patients and families.
Thanks, Carissa. Okay, so just a couple of more logistics. There is also a sign-in sheet that's going around. It's important that you please fill that out with the best email address for us, because we're going to use that information to hopefully register you for our website, so you can receive some updates and around ACEs. So it would be important for you to be able to sign up and get that update. Also, we will be sending that in for CME credits. So without further ado, what I'm going to go ahead and do is share my screen so you can see the PowerPoint presentation. We may need to make edits to the presentation slides, so we're going to go ahead and just show you it for now and then send you a copy of it after we make the final edits. So let me just go ahead and share that. Give me 1 second. All right, can everybody see that?
Absolutely.
Perfect. Okay, so while I'm going over the presentation slides, I'm just going to go ahead and take myself off camera. Okay. So for CME credits, for those of you who are able to receive them, there was a registration link that was sent on the calendar invite, or I could share that after the training. Please make sure that you individually register to receive the credit. Then also for the hours, it's a 1.25 AMA PRA Category 1 credit for physicians, and then a 0.1 continuing education units for other professionals. This is your training team. Our director, Lena, is actually on vacation. So it'll just be myself, Mernell, and Carissa presenting today. What are we going to do? So the training objectives is to review the NPPC, which is the National Pediatric Practice Community and Partnership Engagement, review the science of ACEs and toxic stress, orient providers and staff to ACEs screening, rationale, and protocol development, and discuss screening protocol and practice with sample scripts. If we have the time, sometimes if we don't have it, we will be able to provide that practice for you either offline or within your own site. So hopefully we'll get to do a couple of those. Review education tools, documentation, and additional resources if applicable. Let's go ahead and talk about NPPC a little bit more in detail, as well as the organization that I'm from. So Center for Youth Wellness is a pediatric organization based in San Francisco. We are focused on early childhood adversity and addressing adverse childhood experiences for ACEs and pediatrics. We are excited to work with all of you to improve care for patients and families affected by ACEs and toxic stress, and we work to transform how the field of pediatrics addresses the issue. We'll briefly talk about how adversity plays a role in a child's life and how they can be resilient to it. And then being able to predictably and compassionately be available for children will help their resiliency. Using a formal screening tool will support and evaluate how best to do this process. So about NPPC, we are a learning community of pediatric medical providers who are leaders in advancing clinical practice around ACEs and toxic stress in primary care. Our goals are to engage providers as champions on this issue, provide tools, resources, and training, coaching needed to make ACEs screening and the integration of a toxic stress framework a reality in practice. To ultimately build and become a hub for learning about ACEs and toxic stress as they relate to pediatric medicine. Our vision is that all primary care pediatric medical providers implement universal screening for adverse childhood experiences and routinely use an understanding of ACEs and toxic stress to enhance the quality of patient care and health outcomes. So this project currently has a few different areas of work. We've convened a virtual community of medical providers interested in this topic, and we also provide direct technical assistance and training directly to medical practices to implement ACEs screening, which is what we're hoping to do with all of you. Basically, having one practice teach another as it gains traction nationwide. Our website, go to this right now, it's nppcaces.org. This is what we're doing with the sign-in sheet when we're asking if you wanted to sign up for NPPC. Please say yes. We encourage everybody to get connected. With the NPPC Virtual Network, we're committed to building a national community of medical providers using an online platform to promote shared learning, disseminate best practices, and cultivate advocates in the medical community. And as of May this year, go back to this slide, NPPC reached our goal of 1,000 members representing 450 organizations. We reached this goal even with the launch happening about 2 years ago. So we definitely are growing. All members who join have access to our member website. This is a comprehensive online resource center for tools and materials to support screening, implementation, and you'll also receive newsletters, announcements for upcoming events such as other webinars and up-to-date information from the field. Our partnership, we truly value it. This practice has yet to adopt an ACEs screening protocol, so we provide tailored support, training, technical assistance, and coaching around all aspects of developing and implementing this protocol. We know that implementing screening can be complex, so we have the expertise and tools that can help your practice implement screening in an effective and efficient way. So as I'm going over this information, I know that maybe questions might come up. To save the time, we're asking that questions be held off till the very end of this ACEs Science section, and then at the very end of the training. If a question is urgent, there is a chat feature available. You can go ahead and jot those down and we'll answer it in the order that it appears. Or Katie, if you want to ask a question, Chris or I can jump in if it's something that we need to address in real time. Okay. So now let's talk about the ACEs science. ACEs, or adverse childhood experiences, are potentially traumatic events experienced before the age of 18. The term ACEs comes from the Adverse Childhood Experiences Study, or ACE study, conducted in 1998 by Drs. Vincent Folletti and Robert Anda. It was one of the largest investigations ever conducted to assess connections between experiencing adversities in early life and having health outcomes as an adult. The study is the basis for 10 core ACEs, as you see on your screen, often characterized in 3 categories: abuse, neglect, and household instability. These include physical, emotional, and sexual abuse, physical and emotional neglect, and living in a household where a member has a severe mental illness or substance dependence, where the child has witnessed violence against their mother, or where there has been separation from a caregiver due to incarceration, shifting parental relationships, or divorce. Many ACEs screening tools screen for additional adversities in addition to the core ACEs you just saw. These additional adversities include hardship or significant life events such as the death or illness of or separation from a caregiver, forms of violence and bullying, and discrimination. These experiences impact a child's health in the same way as the 10 ACEs. Therefore, screening for both ACEs and additional adversities provide a more comprehensive assessment of risk factors for long-term health in a child by combining both individual and community environment level health items. This slide is pretty striking. What this shows is that ACEs is actually very, very common. among the population, with over 2/3 of the adults population having experienced at least one ACE, we have data that shows that nearly half of all children today have experienced at least one ACE, and that ACE accumulates over childhood. So I'm not going to go over too much of the stats, just showing this for you as an overview of why this is so important. So it's just a broad overview. Here we pulled out some information specifically to North Carolina. You can see here that nearly 24% of North Carolina children have experienced 2 or more ACEs, and almost a quarter have experienced at least one ACE. We have data that compares what a child in North Carolina who has 1 or more ACE may experience, both good and negative, compared to nationally. Of course, we know that while the prevalence of ACEs is common across race, gender, and other groups, certain groups are still disproportionately impacted. Those who might be most likely to experience ACEs may certainly find that adversity exacerbated by environmental and structural factors such as poverty, racism, and discrimination. So this ACE study and subsequent research has pointed to a dose-response relationship, meaning that the more ACEs that someone has, the greater the likelihood of negative health outcomes in adulthood, leading to the causes of death in the US, such as heart disease, cancer, chronic lung disease, and addiction. So in this slide, we show that those with 4 or more ACEs are twice as likely to develop heart conditions. They're 3 times as likely to have chronic lung disease and 11 times as likely to develop Alzheimer's. We're talking about ACEs as a potential root cause of some of the most costly diseases. And ACEs just doesn't impact health in adulthood. Many of the health and developmental concerns associated with ACEs also appear during childhood. Among infants, studies have found associations between ACEs and growth delay, cognitive delay, and sleep disruption. In middle childhood, we find associations between ACEs and asthma, learning difficulties, behavioral problems, just to name a few. And in adolescence, we find associations between ACEs and violence, bullying, smoking, teen pregnancy and teen paternity, and weight management. So the question is, how do these early social experiences turn into health-damaging ones? What we now understand is that these early experiences act as a stressor on the body, and doing so activate our stress response. So while this stress response is highly adaptive and generally functions well, when it is activated over and over again, it becomes really health damaging. So let's look at the spectrum. Okay. This shows us the spectrum of the stress response, including positive stress, tolerable stress, and toxic stress. The physiological response to stress depends on the nature of the stressors and the availability of buffering and coping strategies. So a positive or tolerable stress response is characterized by a return to the homeostasis, whereas a toxic stress response induces lasting changes. Toxic stress is characterized by prolonged or frequent activation of the stress response, caused by factors such as ACEs that leads to the disruption in the way our neuro, endocrine, and immune systems work, leading to negative health impacts. So let's look briefly about how this impacts the body. So some of the neurological effects can include overactivity and difficulty turning off the stress response. So this includes increased fear response and increased risky behaviors. The immunologic effects can include increases in infection and chronic inflammation. The endocrine effects can lead to changes in hormones related to growth, puberty, and metabolism. And research has also found epigenetic effects, which includes changes in the way DNA is read and expressed, and increases risk for diseases such as diabetes and cancer. There can also be substantial individual variability in how early adversity can toxic stress show up over the life course. So in this image, we see a few different possible trajectories as examples. First, starting at the top, it's possible that an individual who experienced ACEs actually doesn't present any symptoms and ends up having a pretty healthy life. But when you move to the very bottom, we see an individual who experiences toxic stress. We see that disruption, which manifests as social or cognitive impairment, leading to the adoption of health risk behaviors and leads to disease or disability. These are likely individuals that those of you who are providers already identified through your practice as needing extra support or intervention. Those who have behavioral symptoms are in many ways the lucky ones because they usually receive some sort of intervention. Because in the middle, we see a child who has experienced toxic stress, but perhaps doesn't present the more obvious behavioral symptoms. Perhaps their symptoms are in the form of uncontrolled asthmas. So the child has no recognizable symptoms, but as an adult still experiences premature disability or disease. This shows the importance of screening, as not one person will experience things in the same way. But what we also know is that some individuals do and some individuals don't experience toxic stress as a result of negative experiences. There's a lot of individual variability. So here's this slide. Think of it pretty much like a weighing scale, weighing the things that are both good and not so good that may affect a person's health. The positive things are called protective factors, things that help create a safe and stable foundation for a child. The other end of the scale holds the bad things, or the not so good things, or risk factors. ACEs are considered risk factors. So there's this middle part, the fulcrum, which is the individual's biology, their genes, and our biology makeup may make us more or less susceptible to stressful experiences. So the fulcrum is positioned on the scale, but where it's positioned would be different for every person. It affects how much leverage either protective or risk factors have in shaping our life outcomes. So for example, someone who has their scale weighed down by risk factors is also more biologically susceptible, so therefore will be at greater risk for stress-related diseases. So again, this is just a brief overview of ACEs science. I know I covered quite a bit of slides for you and kind of read through a lot of content, so I'm just going to pause there before we transition to the Carissa and the screening to see if there's any questions.
Does everyone feel good about the ACEs science?
Yes, we do.
Okay, excellent job.
They're
We don't
pros.
not the unmute, but we feel good about the ACEs science.
Awesome,
Okay.
awesome. All right, well, if there's no other questions on this section, we're going to go ahead and transition over to Carissa. Carissa?
Great. Thank you so much for your time today. I appreciate it. So we'll talk a little bit about the ACEs screening process and how to successfully implement that in your practice. So we know a few things from our pilot sites that we have helped previously and from some of our research and studies along successful implementation. As far as ACEs screening, we know it's the perfect partnership when it comes to the primary care setting because pediatric and primary care is the ideal place for health promotion. You already do a great deal of other screenings, so integrating this into your current screening processes can be an ideal sort of layout for successful implementation. And we also know that for the most part, having as a nurse worked in both adult and pediatric care, there's a special relationship that you don't always see in adult care that occurs in the pediatric setting, where you have the opportunity to not only influence the patient's health, but also the parents and the parenting. So given the fact that you also do a great deal of anticipatory guidance in your practices as well, this is a logical place to implement ACEs screening. Next slide. So the way we approach implementation is through quality improvement methodology. I'm sure you've all heard of the PDCA cycle. So we apply this methodology through the implementation of screening, starting with the planning component, talking about identifying a target population to be screened, a screening interval, the rationale for screening, then working through the final implementation workflow, creating operational definitions for measures, and then launching your screening and looking at your data every month for 6 months and other insights, how staff have handled it, any barriers that have come up. And at the end of that, we write a summary report of your PDCA so that you have a full PDCA model that's documented for other needs that you might have within your practice to meet requirements for Joint Commission or for grants, as well as your patient-centered medical home designation. So next slide. When we look at this through the lens of what we're actually doing here, today we're finishing up our planning component, and next you all will start with the launch, and that will actually be the beginning of the do component. And as you can see, as we study the results over the next 6 months, we'll finalize the check component, and at the end of that 6 months we'll do an analysis with you as well to talk about whether you're ready to revise and sustain your efforts or spread them to other locations or age populations. All right, next slide. So let's talk about some of the key steps for implementation of screening. So certainly determining the rationale for your screening is key. Selecting a patient population to start with, really mapping out the workflow. Part of the reason that we folks from Center for Youth Wellness were on site a couple of months ago was really to understand your clinics. We had the pleasure of being there with you in the Blakeney office and understanding your workflow. And our goal, really, to be successful, we know our goal must be to implement screening in the most or the least disruptive way possible, to integrate screening into activities that you may already be doing and minimize any changes or disruption in your current workflow. We then generally ask groups to identify the tool that they'll be using. In this case, you'll be using the ACE-Q. We'll outline a scoring algorithm and then develop an education and intervention plan. The good news is we have patient handouts for many topics related to ACEs, and even what we at the Center for Youth Wellness call job aids, which gives you a couple of bullet points to talk about each of the education handouts that we provide to you. So if you're not sure what to say about them, you've got some easy language there provided for you. So basically a kit, all wrapped up in one to help you be successful in screening. Next slide. So we have heard from our work with you and other clinics that the rationale, other Atrium clinics, the rationale to screening is to better assist your children on site that are identified for patients with additional needs, to continue to improve your internal systems. I know you've got lots of resources in-house and staff that have connections with those resources, so how to use those a little bit better, and work on connecting children to services related to toxic stress. As we've heard, the goal is to identify and screen children at the 3 and 5-year-old well child visits, and your colleagues at Myers Park are also screening clinics, an obesity clinic patients as well. I had a little blank on the name for a moment, but I got it together. So next slide. All right. I know this is very difficult to see, but you've got this in your packet. This is the Center for Youth Wellness ACE Child ACE-Q questionnaire. So this will be administered to parents. You'll hand this to the parents and ask them to fill it out for their child, 3 to 5-year-olds at the well child visit. An important thing to note is this tool is considered a de-identified tool. And I know in the medical field that means something different to you all than it does more on the public health and screening side. So yes, of course you'll have the patient's name on this tool, or you will identify these answers corresponding to a specific patient. When we say de-identified, we mean we're not asking yes or no to each of these questions. We're asking that families consider which of the items they've experienced in section 1 and put the total number they've experienced in the box to the right. The questions in section 1 are specifically related to the 10 core ACEs in the original Folletti study. The section in the bottom, section 2, are other factors related to social need and community encounters that have been addressed in the literature predominantly in the last 5 years, as well as items that have been brought up by our community advisory committees. And so we ask that you, again, have patients read the statements and fill out the sections 1 and 2 with just one single number. The rationale behind that is simply that this is a tool that is meant to screen for the potential or the risk of toxic stress. This is not a screening tool for abuse or neglect. It is simply a tool to screen for toxic stress. And so the presence of higher numbers indicate a higher risk for toxic stress. We certainly would recommend that you continue to monitor and evaluate children and families for abuse and mandated reportable items, just as you always do in your current practice. And we firmly believe that your clinical expertise and judgment could never be replaced by a screening tool such as this, and that your clinical judgment certainly would prevail over a questionnaire like this, or any concern that you have related to a mandated reportable item. Next slide. So we have identified a workflow that we think will work well for your practice. And this was provided in conjunction with your leadership. And that is to introduce the tool by the nurses and when the patient is roomed. And this is simply due to the fact that we've seen over and over that a brief explanation is really needed to facilitate parents filling out the tool correctly. And when that's done in the waiting room, we often see very poor compliance with completion or just zeros typically. So once the nurse checks with the patient and sees that they've completed it, they will complete the screener results in the EMR, which I'll show you your build in just a moment, and then transfer that information to the medical provider. The provider then will review the screener and assess for symptoms associated with toxic stress. We'll talk about that too in just a moment, and then make the appropriate referrals or determine the next steps to follow up. This may include a referral to your referral coordinator or linking families with other services or patient education. Again, if the provider feels or the nurses feel that there's a concern for maltreatment, we would encourage you to follow your normal process of communication and handoff with the team and report appropriately to Child Protective Services. Next slide. So when we look at a scoring algorithm, we typically recommend a 3-tiered intervention. So for your patients, when they identify that they have 0 ACEs, we would categorize that as low risk. This would also mean that they're not having any symptoms or no clinical manifestations of toxic stress. And we would ask that you provide anticipatory guidance and handouts on what are ACEs and toxic stress. For patients that are scored with 1 to 3 ACEs with no physical manifestations, we would identify those as intermediate risk and ask that you, again, provide additional education, patient education, and anticipatory guidance on what are ACEs, toxic stress, and how to build up those protective factors related to resilience. There may be additional referrals such as the CC4C or Triple B parenting or to your internal referral coordinator. And the provider may also schedule a follow-up in the next 1 to 3 months just to check on how the parents are doing. Now, when patients score a 1 to 3, and that would be adding the top and the bottom sections together for all of these, or they have a score greater than 4, so 1 to 3 with symptoms, or a score of 4 or greater with or without symptoms, we would consider these patients at high risk for toxic stress. We would identify what their clinical manifestations are with the guidance of the provider, and then provide that anticipatory guidance with the appropriate referral or link to clinical social work or mental health, and the provider would likely schedule a follow-up in the next 1 to 3 months to check on the patient, see how they're doing, and reassess the symptomatology. Next slide. So this is the symptom checklist that I was referring to. And this is broken up into the systems that we know are impacted from the research by system and by age group. And so you'll see across the top header the neurological impact that we often see associated with ACEs, endocrine, and the immune inflammatory, as well as the unhealthy coping. And the top boxes on the left is for multiple ages, and the bottom box on the left identifies issues or concerns with infants. Now, I'd like to point out that we are not by any means saying that asthma is a direct correlated condition to ACEs. When you look in that immune inflammatory box and you see asthma or eczema there, what we're really stating is please consider frequent or uncontrolled asthma or eczema as a potential symptom related to ACEs. It was just very difficult to say frequent asthma exacerbations in the patient or client that you feel are compliant with their medications. That didn't fit very nicely in that box. So again, these are considerations for you to link to the toxic stress, and we would ask that you use your clinical judgment going forward. Next slide. So we're going to I'm just going to show you very quickly where the documentation is set up for you, and you have a beautiful and very sophisticated build within your EHR. In fact, the best I've ever seen to date. So hug your IT person when you see them. Please be kind to your IT people. They've worked very hard with us, and all of your trainers there have been amazing. So the first step will be to access your clinical forms section, go to the ad hoc area. You'll click on the ambulatory child visit form. Next slide. This will pull up the normal intake for you. And then you're going to click on the screening tab. You'll see this to the left in your navigation tool. And type in ACEs screening, click yes, and then this, then the ACEs screener will pop up into your clinical screening page. Next slide. So what that's going to look like is when the provider comes in, they'll be assessing for symptoms, and they'll go to the scales and assessments tab. Next slide. And this will pull up the provider form. Here you can click this. I know this is a bit confusing, but this will be the area that the nurses will fill out. So they will click parent or caregiver report for the child. We have also added the box for in the future when you are possibly screening adolescents when they are screening for themselves. You'll be able to check that box, so you'll have additional functionality built in for future spread. So for the nurses now, you're going to stay in this left column. You'll be adding the score from section 1 in the top box there, and then from section 2 in the bottom. These will auto score and populate. It'll be really important too if the family refuses to fill out the questionnaire, which is completely fine. You can just click caregiver refuse, but this will be really important as this is one of our key metrics. Next slide. And don't worry, you don't have screenshots of these, but you will be provided them after the training, and you'll have some additional opportunity to review this, ask questions, and practice with some of your training colleagues on site. So the provider will have this screen. So up above, you'll see where there's a box to the far left, whether or not symptoms are present. So the provider can click here, symptoms not present, and then that's fine, or symptoms of toxic stress present, which automatically helps with the scoring component. It automatically populates the risk given the score. So that 1 to 3 plus symptoms would be a high risk. And so you can see that that's been populated here. The provider has the opportunity to change that up or lower given your clinical judgment. And you also see down at the bottom, you can then check what specific symptoms are present as far as documenting what to monitor in the future. Next slide. Then the additional component that will be critical will be documenting what actions or referrals are made. So not only did your IT person build a wonderful way to document, but they have built some guidance underneath the referral and actions component just to remind you what potential interventions can be offered here. So an easy guide for you, and you can click the patient education that's provided, and then the referral section in the yellow. And if you have any other detail you would like to add to the referred to box to the right, it's blank. Again, the referral box is critically important as this has to do with your 4 key measures that we'll be looking at, which I'll go over in just a moment. But you'll want to know what patients had a positive score, how many of them had a referral made or were already in services, or if they declined a referral too. Next slide. So these are the 4 metrics that we will be monitoring to assess the success of your program and implementation. So the percent of patients screened who are eligible in a given month. So each of those 3 to 5-year-old well visits. Again, it will be important to make sure that you're using the right patient visit type when you're scheduling patients, because we'll be pulling the denominator or those eligible patients by that appointment type. So the well child or annual visit type will need to be documented consistently. We'll then be looking at the number of 3 and 5-year-olds that had a positive screen. So we're either identified as intermediate or high risk over all of the patients that were screened. And then the percentage of patients with a positive score who had an appropriate referral. So we'll be looking at the 3 to 5-year-olds who had a positive score, who had a referral, or where it was documented that they were already in services. We don't want to penalize you for patients who are positive, but you've already identified that through other means and have made appropriate referrals. And then we'll look at the percent of patients refusing screening. That is often an indicator that we need to do a refresher training on explaining the tool, or maybe do more marketing, put up more posters around We Screen Everyone and the description of the tool and why and how you're using it. Next slide. All right, so I think it's really important, and I'd like to take a little break here. I know y'all are probably have the post-lunch fatigue and blues. You've got the post-lunch blues, I bet, for sure. So I'd like for you to take just a couple of minutes and turn to your neighbor and practice talking to them about toxic stress and what are ACEs. As if this was a neighborhood question, or a friendly neighbor heard that you're doing something new in your practice. So explain to your neighbor what are ACEs and what is toxic stress. I want to hear lots of chatter.
We're talking. We had you on mute. Sorry.
Good deal.
Are we muted now?
No.
Yeah, I had actually one question we have to consider about the denominator.
Go ahead. Yes, please, go ahead.
For most of our patients, they'll be scheduled under well child visits for those 3 and 5-year visits. But new patients coming into the practice, we have a different visit type.
Okay.
It's a new patient visit, and that could be a sick visit or it could be a well visit. So I don't know how we're going to capture those patients who are new 3 and 5-year-olds coming in for well visits under the new patient appointment type instead of the well child care.
Would you want to screen them at the very first visit? Or
guess
would
not,
it be
maybe.
better maybe to wait?
I'll think about that. I don't know why we wouldn't. You know, there's
only patients or
no,
No,
just
3 and 5-year-old
the 3-year. Yeah, I mean, I don't know why we wouldn't screen them at the first visit. I mean, we don't really have a relationship with those families, I guess you could say. So maybe we need to have a little bit more trust with the families before we start with this kind of screening.
Mm-hmm.
But it may be our chance too, you know.
Sure. I think that's just an important consideration, and I would recommend that you just try it out a couple times and then decide what you'd like to do. See how it goes.
But it just in terms of the data being true to itself, I mean, if we screen a new 3-year-old who's not in that well visits appointment, but we do the screening, that's going to influence the numbers in our favor, I guess, right? And
right.
only help. But
right.
it may not be as accurate.
Will they make the numerator either then? They probably won't make either one, will they?
Well, it's that were screened, right? So they're
So the
looking at the
numerator
number
will
of
be higher.
screens. So if we do the screening in the EMR, they'll get captured,
Okay.
but they won't go to the denominator.
Okay.
So even though we
could
have period,
cross-reference the appointment type and only count the scores that have the corresponding well child visit. So then those wouldn't hurt you or help you.
okay. Right, so we could still do it, it just wouldn't go to the data set.
Right.
Okay, gotcha.
Okay, do you guys want to practice a little bit more or you want to move on? We'll have more practice time.
I think we're practiced well.
Okay, excellent. We will move on then. Next slide. So a couple of really easy concepts or key concepts and easy comments that I like to use with families when I get a little bit stuck and I'm not sure what to say. These are some of my go-to statements. Just, ACEs are common. The more ACEs you have or you've experienced, the greater the chance for toxic stress. ACEs accumulate over time. I think it's important to say we can't unexperience something, because people often think, well, that was a long time ago. We've resolved the issues around that ACE, but that is still an ACE that the child or a teen has experienced over their lifetime. So also reminding families, giving them some hope too, that ACEs without protective factors can lead to illness, but ACEs and then building protective factors can build resilience and help shield the child from the effects of toxic stress. And then just to say, toxic stress or really difficult experiences can affect our bodies, not just our minds, but our bodies too, and can make us sick. So just a couple of easy points to talk to patients and families about. Next slide. So it sounds like you guys are good on this one. Let's keep going. We can integrate this into another activity in a moment. So in your packets, you do have a sample question or a sample script for administering the ACE questionnaire. This would be something that the nurses would say, and I think this is critically important that you're comfortable saying this and explaining how to fill out the tool properly. So just as you normally would say, we have some forms we would like you to fill out so your doctor can understand how your child is doing. This one is called the ACE screen. We screen all of our patients 3 to 5 years old so we can understand what they've experienced. So when you look at this form, you're going to read the statements and just write the total number of events that your child has experienced in the top section and the total number in the bottom section. You'll see on the script it says exposed to. I like to replace that word with experienced. Just a little less clinical in our description. Next slide. And so this would be, these are some scripts or sample scripts if the questionnaire is positive, of how the provider or maybe the referral coordinator can help to get some additional information about what the patient and family have experienced, what particular ACEs they may have been exposed to, or how you can help them or facilitate the best referral and receptiveness for a referral. So just saying, we ask about ACEs because we care about you and we want to understand what your child has experienced. And the more we understand about you, the better we can support you. I think it's a wonderful thing that there is a universal need by all human beings to be understood. And so tapping into that, I think, is critically important, and it helps to diffuse any concerns or fear about reporting, investigating families feeling like they're being profiled, helping to provide the rationale for why you're screening, really does help to set the framework and a basic understanding of why you're asking this type of information for families. And then, taking that a step further, if the questionnaire or the screener is positive, having a statement readily available in your mind that you are comfortable saying might be something like this. Because of what your child has experienced, or because of the score here, I'm concerned that this might be contributing to some of the problems, like in a 5-year-old per se, regression or regression to bedwetting, or really difficult eczema breakouts, or a new onset of obesity, and a lot of different types of eating patterns that are newly developed. And then to make sure that you close out the conversation with a positive comment. The earlier we address these types of stressors, the faster the body can work to adjust and heal. Next slide. All right, so I just want to provide this for you. We're going to do kind of a case study here. This is a patient mom who filled out a questionnaire for her 3-year-old child, and she marked it a 2. Now, as the nurse who's looking at this, what are you thinking the score potentially may be? Now, keep in mind, we don't know the symptoms yet. So it could potentially be an intermediate or a high risk. So after the provider assesses for symptoms, it would be clear whether or not the patient was a low risk or intermediate risk. So let's say in this case, the patient does not have any physical manifestations or symptoms. So they would be an intermediate risk, and the actions that you would take, let's see, next slide, is that here? I'm thinking it's not. Aha. Changing gears just a little bit. Second case study, this is for a 3-year-old who has a score of 4. So given the scoring algorithm, this patient would be categorized as a high risk. Very good. So with or without symptoms, this patient would be a high risk, and you would consider them for some of those additional referrals. Think about this in the context of a 3-year-old. They've already experienced 4 of these Section 1 stressors. Now, in both of these examples, we did not have any components in the bottom section, but again, you would add the top and the bottom together for your total score, and that would give you your help to clarify your risk category. Next slide. Now this one is a little bit of a trick. I'm going to see, so if you could unmute yourselves, in the case where this is a score of 10, what would be the next step that you would need to move forward with?
I don't think that they likely read the instructions and understood what they were being asked to do. Clarify.
That's a great one. If it really turns out to be a 10 in the top box only, and not if it was a 5 on the top and a 5 on the bottom and you added it together to a 10. But if it's a 10 in the top box, then you do have to have a further conversation about the mandated reportables, because they have identified that there has been physical or sexual abuse. So this is the only instance where you know that you've got to do some further assessment with regard to the particular ASIN. Now, I will tell you, I just want to share this with you because every practice has a great deal of concern that this is going to happen all the time. And I can tell you, in all of the practices that we've helped go live with screening, we have not ever had a 10 reported. Now, there have been instances where the score was much less than a 10, and when the patient family was asked further by the provider, there have been cases of physical abuse or sexual abuse that have been identified, but that likely would have come out anyway. The patient family was ready to talk about that, and this just gave the provider the platform to tee that up. Now, again, I know this can be a little bit scary because many providers and practice clinicians are thinking, you know, any family that fills this out and puts a 1 in the top, that 1 could be physical or sexual abuse or neglect. That would be a mandated reportable. And I understand your concern there. But this, again, is a screening tool for toxic stress. And if the family isn't ready to speak to you about the experiences they are going through, they're not going to tell you about it. And if they are ready, this is a great way to set the stage for that and provide them an opening to talk about that in a non-threatening way. So again, your clinical judgment will never be trumped by this questionnaire. If you have a concern or you feel the need to assess further, your clinical judgment and expertise are always the right answer. And we know that you will likely identify those patients that are at risk and need additional support and services through state and legal protective services through your own means and judgment. Now, we have sought clarification related to the score of 10 being a mandated reportable through many discussions with our legal counsel, both in San Francisco and California, and on a national level, just the perspective of all states and mandated reporting for providers. So we feel very confident that this is the one case where you would need to take additional steps and do have additional information from our legal team if you have any questions about that. Next slide. So now let's do the role play where you one person is the nurse that's handing out the ACE questionnaire, and for those of you who are going to serve as the colleague that's going to serve as the patient family, I would encourage you to really be as ornery as possible and give your colleagues a good run for their money. And take a couple of minutes just to explain this, you know, what the questionnaire is and why you're asking about it, and then take turns. So we'll give you 5 minutes. All right, we're going to get back to it. I hope that went well for you and you got some good practice in.
Hi,
But that's
Carissa,
why-
hang on one
yeah.
second. We're still in the middle of explaining
Okay.
something else. 1 second.
But that's why they want it to be indistinguishable as to
Right.
which ACEs are the issue there. So you're not, and if you notice the symptoms you can document
Right.
saying poorly controlled asthma
Take
or
the individual ones, yeah.
right, but the ACE is, the key to the 10 ACEs or the extra questions at the bottom that impacted outside the original study. You're not identifying those specific stressors primarily for that reason, so that they can feel that it's not documenting a paper trail that's going to come back to haunt them. It's purely to identify who can use additional support services.
Right.
Right. And we're not even providing those directly, right? We're
Right.
making referrals to hopefully the community resources that exist that can come in and help. The problem that we always forget about is we're seeing these patients already, right? We're just missing all of this until it's a big enough of an issue that it's a bigger problem.
Right.
And so, it's the same. We're not getting new patients coming in to fill out ACEs forms. It's our patients that come into the office every day, and we're trying to take the best care of them possible. So, but right, but that's the point of just putting a total there, is that we're not reporting any specific adverse childhood event. It's the total exposure.
Gotcha. Do you have time for a quick question, or would you prefer me to save it until the end?
No, now sounds like a good time.
How often in clinics who are doing this already have you seen parents just not really not follow the rules and circle individual events or experiences versus just putting the total in? I feel like that potentially could be an issue.
Sure. It happens pretty often in the beginning until the staff get really comfortable and sort of adamantly saying, just put the total. When I explain it, I say, you don't need to circle any. I just go ahead and say that outright.
Right.
Now, if the family wants you to know, then that's okay. I mean, that's a good thing. You can address that in your note. You're still going to document it the same way in the EHR.
I just think I could see the potential downfall being if someone says, what are you going to do with this information? And we say, hey, this isn't to report or get anyone in trouble. This is to understand what your child has experienced. And yet then they circle something and then we say, oh, actually it's changed. This is something we have to report.
Right.
I just didn't know how often that was something that you had run into thus far.
We do see it some, but again, it not typically too often, and it is very, very rarely something. The things that are circled are very rarely the mandated reportables.
Gotcha. Okay. Thank you.
Yeah. I will also tell you this, from the multiple pilots sites that have gone live, and that we've had an analysis of 6 and a year's worth of data, we see that about 30% have a positive ACE in the intermediate and high risk, and of those 30% in a population that's screened, about 10 or 8% end up being a high risk. So it's not a huge population, and it does correlate with the national averages that we see. So I just want to also share with you that I don't want you to be concerned, and we've heard this over and over, that everybody is going to have a positive score.
Right.
And overwhelm your practice. In many ways, we've heard over and over that having the screening tool in place has refined and streamlined the referrals and made it much clearer who needs to be referred to what services. So again, I just want to encourage you to think about that. So let's look at the next slide. We'll just be going over the educational handouts now. We have 3 handouts written into your algorithm. The first one is the what are ACEs? The second one is the toxic stress handout, which You should have in your packet, they may look slightly different, but the toxic stress handout is a great one to talk about the physical manifestations. And then, excuse me, looking at the last handout, how to reduce the effects of toxic stress, talks about some of those protective factors. We have these all in English and Spanish. We also have handouts on the 6 protective factors that have been validated in the research to help build resilience and combat the effects of toxic stress. And those are sleep, nutrition, exercise, mental health. I always forget the last 2. A positive relationship with an adult, and then did I say sleep? I think I got that one. Anyway, those will all be provided to you as well in English and Spanish. And we have a job aid. If you'll go to the next slide, we have a job aid, as you see here, for each one of the handouts that give you some guidance on comments or things to say when you're introducing the handout. So I like to use this one. I wrote this part of the job aid. I like to use a little bit of humor, and so I say, when I first heard of ACEs, I didn't understand what they were. We always have to have some fancy name for something in the medical field, right? So ACEs are just difficult or stressful times in our lives, and this handout lists some examples of the ACEs that have been studied. Next slide. For the toxic stress handout, you can see that some things here that are easy to say. Having a lot of stress over time can make you sick. Do you think this could be happening in your family? And just we want to help. Is there anything that we can help you with today? I always think that's an important thing to add. Or what would be the most important thing that we could help you with today? Again, addressing the effects of toxic stress is a marathon. It's not a one-time intervention. It may be multiple exchanges with the patient family before there is a receptiveness or willingness to address these. And so oftentimes I talk about the concept of just planting a seed, doing the initial screening and getting your practice and your community comfortable with what you're doing with this initiative. Oftentimes is just started by planting the seed of screening or even offering the screening. It's okay if patient families refuse. The important messaging, if a patient family refuses, is just to say, that's okay. Here's a handout about ACEs. If you're interested, read it. We just like to know what you're experiencing so we can help your child be the healthiest and the happiest they potentially can be. And I also joke there and say, you don't have to read this handout. You could throw it away on your way out. But it's important that we tell you about it and give you a chance to ask questions. So, and then you can follow it up with maybe next time you'll be willing to fill out the questionnaire. If not, that's okay too. Please keep coming back. So let's look at the next slide. This will is just a reminder. Make sure that you give advice with only permission. Use open-ended questions. For those of you who are familiar with the love and logic model, I oftentimes will talk to families and say, I have had another family that's gone through similar experiences as you, and they worked on really establishing a good sleep routine first. So you're not giving them advice, you're just telling them what another family has done. And I will say, and that worked really well for them to help, be able to address the other issues going forward when everyone was getting good sleep. And we know that's a protective factor and makes everybody more resilient. So would you like the handout on sleep and ACEs? So a good way to talk about that and bring that up in that context. Again, you'll have all of those patient handout materials available to you. All right, let's look at the next slide. We're just gonna, we have just a couple of minutes left. I just want to talk to you also about concepts related to trauma-informed care, and just make sure that, you know, your practice builds an environment that is trauma-informed, and some of those steps, the ABCDEs, as we like to say, just having an awareness of how stress and compassion fatigue is affecting you. Make sure that you're really working on your personal, professional work-life balance, and connecting to your peers, both at work with regard to ACEs. We like to talk about having a safe buddy, someone that you can talk to in case you're triggered related to a questionnaire that's filled out by a patient family, or if you have some concerns that it wasn't filled out accurately and you feel like you're missing something, please talk to your colleagues. Find that one person that you can always just debrief with. And then as a group, if you have an experience that is really a shocking revelation about a particular patient family, come together and talk about that, debrief it. Or if a patient escalates about the questionnaire, talk about that too. It may happen, it's okay if it does. Just talk through what could have gone differently, and how you might approach it the next time, with zero blame in mind and in a really positive, non-punitive environment. And if you find that you're having some anxiety or burnout, please don't forget to access your own employee assistance program. You know, I like to just say that I like to remind you all that the work you do in the community is really it is really a mission. It's missionary work, and so your commitment to your community and screening patients for ACEs can be taxing, and so we want to make sure that you guys take really good care of yourselves, so you can continue to leave a legacy in your own community, helping patients to be happy and healthy. And if you don't do it, you know, we're not sure who will. So please take care of yourself so you can be in it for the long haul. All right, any other questions? We can, you can put up our contact information there. If you have any questions, please feel free to email us. I think we are still waiting to hear when you want to officially go live. You have thoughts on that?
Dr. Pat and Dr. Mehta and I have been kind of discussing it. So I think we want to go all close to the same time, but maybe just not all right on the same day, kind of sequentially. But we got to make sure we have all of our referral eggs in a basket, so to speak, before we do.
Yeah, very good.
That was going to be my question, was on the referral side of things. Are those community resources already aware that they may be getting more traffic from us? And
absolutely, and they are. I think the word is cautiously excited about it, actually. Okay. So because their mandates are to, you know, help these kids and families, right? And so whatever we can do to identify them early. And the other thing, everybody's nervous that we're going to find these things and what are we going to do with it. But what we do right now is when we don't find it, then we have the anxiety and depression conferences and the ADD conferences. And, you know, it's going to be time up front, maybe a little bit more, but it's going to really, I think, have a big impact downstream for a lot of those families. But yeah, so we're going to have all the referral parts in place before we go live, and I think they're still looking at mid-September, although I think, correct me if I'm wrong, I think the South Park training is later this week.
Wednesday.
It's Wednesday, yes, so it's not September 10th, but it'll be the 28th, And then I still think they're looking probably for mid-September to go
Okay.
live.
And I would also like to add that when we were there in Charlotte earlier in the year, we were able to have kind of a global meeting with all of the practice medical providers and also some of the community representatives. So people from CC4C were there and very eager to help and talk about how to be a resource to you all. And I was able to meet and speak with Dr. Meg Sullivan, who is the Mecklenburg County medical director. She came to part of our talk and was very interested in availing the services of the social workers to you all and making this a better opportunity to partner.
Awesome. Thank you so much.
All right. Well, thank you all. If there are no further questions, we'll let you get back to important work. But again, our contact information is here. Please feel free to call or email us with any questions or comments. Nobody ever does send me an email with a question, but I would be happy to answer it, as would Murnell or Lena. And we just thank you again for your time and your commitment. So.
Thank you.
Thank you.
Thank you, guys.
Everybody. Have a great day. Bye.
Bye.
Bye, everybody.